For 33 then is we're going to finish up learning plan 2 and start learning plan 3 today. So still talking about anxiety. So again, we're always using that nursing process, and we have to self monitor. So we always ask people to rate their anxiety on a scale of 1 to 10. So they are able to kind of keep track of their own symptoms, right? So we always ask that. And ineffective coping certainly would be a diagnosis for a nursing diagnosis we could use for people. So if they have ineffective coping patterns, chronic low self-esteem, possibly they might not really feel very good about themselves because of their level of anxiety. And some people practice self-mutilation. They cut, burn, scratch themselves, all kinds of self-harm type mechanisms, because that helps them, actually it helps them to feel better. And we'll talk about that a little bit more in Learning Plan 3. So, but sometimes people with anxiety do practice self-harm, so the goal would be to have them to use self-restraint. So planning. For obsessive compulsive type illnesses, the book is saying patients don't usually require inpatient admission. However, sometimes they do. Again, everything's on a continuum. If they're really severe, if their hands are like raw, like hamburger meat, and they can't function on a day-to-day basis, they absolutely might need an inpatient unit. Apparently, there's an inpatient OCD unit at Rogers in Milwaukee, and I know somebody that used to work there, and it sounds like a really interesting unit. Some of the things that they had the patients do, and the staff had to do things also to almost use like a flooding technique to kind of flood them with every possible thing that they, that bothers them. So if germs bother them, they would, somebody told me that they would actually have to like drop a sandwich on the floor and then pick it up off the floor and eat it, and the staff would have to do that too. They would be role modeling for the patients. You're shaking your head. Are you aware of?
I just know that I had a student who would even travel all the way there for their therapy.
Yes.
From Manitowoc.
Yep.
So, and the mom experimented with, who was available in Manitowoc, in Green Bay, and Sheboygan, and ultimately they ended up there. And she said, if you ever have another student like this, you need to get them there. So it must have been worth their time and effort, because they would travel even for weekly therapy.
Wow.
But that student was, we had a 504 plan for him and things at school so that he did not, wasn't penalized in his education because he had a disability that qualified him to this school.
Right, and that it can become a disability.
Oh, it was hugely disabling.
Absolutely. Some people can't function. They can't get out of their house. They can't go to work. So it really can be extremely disabling. Seems like the other thing.
And for the whole family, like the student, he had an issue with, germs in school and things, and the mom would say, I am a professional. I have to get to work, and I can't get my son out of the house. I can't pick him up anymore and put him in a car or get him out of a car.
Yes.
And now I'm late for work, and my husband's late for work, and
yeah. So it disrupts the whole family. Absolutely. Yeah. Yes. I think another thing they did, if I remember correctly, was like they had to like lick the bottom of their shoe, just all kinds of like, exactly, like things that are like, oh my God, really? This person was telling me all these stories about because they had worked there, and I was kind of, but apparently it worked because people do get better. So I beg to differ with the patients maybe they don't usually, but it really depends on the level of impairment. I have a student told me that they knew somebody that kind of had OCD about needing to check things. They were always worried about things. And this person couldn't get out of their house. They were always late to work because they couldn't remember if the curling iron was turned off or not. And they didn't want their house to burn down. So they kept going. They'd start driving to work, go back, and have to come back and check to see if the curling iron was unplugged. And they do that like a couple times. So finally this person had the brilliant idea of taking the curling iron with her in the car. This way she was able to know it was unplugged. It was right there in the car with her, and she could get to work on time. So, for some people, if they can think of some kind of like creative ways around that. So anyways, Many times we have to have community-based interventions, people that's really specialize in that type of illness, provide the best therapy. Active participation in their own planning to achieve their outcomes, and if patients are having severe levels of anxiety, severe levels of OCD, they may not necessarily be able to participate in their planning until their anxiety level is a bit lower. So again, in the implementation, our interventions are going to be different depending on their level of anxiety. So just kind of remember that for test questions too, that when somebody is at a panic or severe level of anxiety, they're not necessarily going to respond to teaching. And even remember that when you're doing med-surg clinical or you're working someday. If patients have a high anxiety level, they're not going to remember what you said at all. They may remember bits and pieces, or they may remember very spotty, or they just may not have any recollection of what you talked to them. So mild usually is the best anxiety level to teach anything. Moderate, remember, you need to do a lot of repetition. And severe responds to step by step, but they're not necessarily going to remember anything past that. And panic, you really can't teach anybody anything during a panic state. We have to lower their anxiety level first. So, all right, I think I'm going to go on back to the case study. If you remember, Anita, this is the one who had her 5-year-old child kind of wandered away from her, but she has a history of panic, so she recalls the help she experienced when treated as an adolescent for panic disorder. I remember my dad anxiously driving me to the emergency room while my mom sat in the back seat, held me, just trying to keep me calm. My dad gripped the wheel like he was afraid we'd go right off the road. When we got to the hospital, I remember a nurse came right out to the car, opened my door. She didn't grab me or anything. She just said, "Hi, Anita, my name is Betsy, and I understand from your mom's phone call that you're having a panic attack. I'm here to help you get through it." Then she held out her hand. I've always felt like Betsy saved me that night. So what was the most helpful thing she did that night? And unfortunately, the correct answer is, for some reason, it didn't show up on the screen. It's cut off. So we're not going to leave her alone, right? And if somebody's in a panic state, we're not going to leave them alone in a quiet, dark space. She might be more frightened. Keep up a steady stream of talk. No, that's too much stimulation. A bright, pleasant game. Again, too much stimulation. So the correct answer, unfortunately, that's cut off is basically to stay with that person and just try to keep them calm. So you might talk to them softly, talk to them calmly, but you're not going to keep up a steady stream of chatter because that would be too much stimulation. But staying with that person when they have a panic attack is really important. Suppose you're a nurse or social worker on duty when a child goes missing, but unlike Anita's child is not immediately found. The police arrive, the parent is questioned, and as the search intensifies, you are asked to remain with and take care of the anxious parent. What would be some appropriate interventions for helping a parent experiencing that panic level of anxiety? So what do you guys think? What should you do?
Maybe like coaching them to breathe.
Okay.
Like relaxation techniques.
Okay.
Just listening to them.
Okay, if they can talk, because if they're in a panic, they may not be able to focus on anything outside of them. But you've got a good point with that, with the breathing. Sometimes you have to kind of get right in front of them and model breathing. And so hopefully, as they're coming out of the panic, they'll see your slow, deep breathing, and they'll maybe start to imitate your breathing. That would be a really good intervention. Anything else?
I would also add like reassurance of just factual information.
Yes. Yep.
And reassurance that you're going to remain with them as a constant presence.
Mm-hmm.
I will stay with you. The police are here.
Yep.
They're doing their job to find your child.
Yep.
Just reassurance. And
Simple.
And maybe even just repeating those same things. Because if she's that high in anxiety, she probably didn't hear you half the time you were saying it.
Right. So keeping that repetition and keeping it very simple, very short sentences, very simple, concrete information. All right. Those are some really, really good things to do. All right. So the implementation, sometimes we do use medications to help people with anxiety or different types of anxiety illnesses, such as OCD, generalized anxiety disorder, panic disorder. So there are some antidepressants that do help with anxiety. Anti-anxiety drugs, benzodiazepines is the biggest classification, but benzodiazepines are addicting, right? People can become addicted to those. There's another medication called Buspar, and I don't know if you've heard of that. Have you given that before? Buspar, Buspirone? Okay, that is not addictive, and it does need to be taken consistently. It is not something that's going to build up. I mean, it is something that builds up in your bloodstream the same way the antidepressants do. It's not something that's going to work immediately to decrease their level of anxiety. So that's the biggest thing to remember about Buspar, is that it's not, you don't take it PRN to get an instant, immediate, within 15, 20-minute effect of decreased anxiety. You have to take it consistently on a day-to-day basis. So sometimes we also might use antipsychotic medications for people that have a high anxiety level. So I do see those ordered every now and then. Sometimes people take Seroquel for anxiety. They might take Thorazine even. That's the oldest medication there is, but I still see Thorazine used once in a blue moon. Zyprexa, I see that for severe levels of anxiety sometimes. And another medication that is used for anxiety, which is non-addictive also, is trazodone. So trazodone can be used for sleep, and it also can be used PRN for anxiety. So it's not a good, trazodone's actually a really bad antidepressant. I don't mean bad antidepressant. It's a poor antidepressant. It doesn't work that well for depression, but it's a really good sleep agent and really good for anxiety. And other medications that we use too lately, because again, not addictive, is something like hydroxyzine or Benadryl are sometimes used for people with anxiety. And I'm seeing that more and more as addiction seems to be a bigger problem. So many of the doctors now are unwilling to prescribe the benzos because people are becoming addicted to them. Or if they already have an addictive disorder, then giving them benzodiazepines is not usually helpful. So I'm seeing a lot of hydroxyzine ordered in the hospital. So you'll be doing med sheets on those when you get to clinical. All right, so lots of different types of drugs that we use to treat anxiety. And of course, we are always doing other types of therapy and cognitive behavior therapy and health teaching just to live a healthy lifestyle, and probably avoiding drugs and, avoiding street drugs, of course, and avoiding alcohol is very helpful, and decreasing levels of caffeine and nicotine if the person is using those substances too, because they just don't help our anxiety levels. Although I've read that like 3 cups of coffee a day is supposed to be good for antioxidants, like other health reasons, protecting your heart, whatever, but too much is, right? I know, maybe I just have to rationalize why I drink a couple of cups a day. So anyways, advanced practice nurses certainly are doing lots of these different types of, you don't need to know the ins and outs of all these different types of therapy. Although thought stopping is something that you can do. And once in a while, students have tried this in clinical if their patient has some anxiety, especially if they have like the obsessive thoughts that just intrude into their consciousness, either with OCD or even PTSD. So that would be if they, well, I don't know, we really probably can't give rubber bands on the unit because some people snap them so much they self-harm and they abrade their skin. But the theory is to like have a rubber band on your wrist and then you snap it every time that thought comes to your mind, and that kind of brings it to your awareness like, oh, I'm thinking that again. And then they stop and they count backwards from 10 and then refocus onto something else. So it's just a refocusing. So I guess you could really do it without the rubber band, but it's something that, it's a technique that you can actually teach your patients how to do. All right. Always want to evaluate, do they have a reduced level of anxiety? Do they recognize their symptoms as anxiety related? And do they still have obsessions, compulsions, phobia, worrying, or other symptoms of anxiety disorder? Are they more or less frequent, more or less intense? Hopefully they're getting better. We did see quite a bit of anxiety this week in clinical also, and last week. So can they use their new behaviors to manage their anxiety? Can they perform self-care? Because again, we always have to remember those basic simple things like ADLs, that people don't shower, they don't brush their teeth, they don't take care of themselves in normal ways when they're experiencing some of these disorders. Or if they have OCD and they are worried about germs, they may be showering and washing their hands too frequently, which isn't good either. Can they have satisfying interpersonal relationship and resume their usual roles? So this is just something that is just kind of an interesting a scale that can be used as an outpatient to kind of measure people's progress. So we do use quality improvement measures and to measure people's progress. You don't need to know details about that. All right, Chapter 16, Trauma, Stress-Related, and Dissociative Disorders. So, PTSD. So first we're going to talk about PTSD in children. So why do you think children would have PTSD? Abuse. That's usually trauma, some kind of trauma, abuse type of situation. A few years ago, I think it's more common that people understand that now, that you can have PTSD, depression, anxiety in children. And I just remember listening to a talk radio show some years ago, maybe 10 or more years ago. And I just remember the announcer saying something about, how could a baby be depressed? How could a baby have issues? And I was thinking to myself, well, what kind of a nice world? You must live in a really nice world that you don't understand that not every child, not every baby is nurtured and cared for, right? Because he just didn't get it that it's possible that a baby even can have depression and certainly anxiety and PTSD all the way through childhood. We can see these symptoms. So what we see sometimes is reactive attachment disorder. So sometimes children, they haven't been taken care of, and so they don't develop that normal bonding. So they really have a hard time bonding and connecting. Disinhibited social engagement is the exact opposite. They haven't bonded and haven't been cared for, but they will just go with anyone. They'll go up to a stranger and say, hey, can you take me home with you? I mean, they'll just go, if you say, hey, kid, come here, they'll go with anyone. That's scary, right? Because then if a child has that disinhibited social engagement, they're likely to get abducted. They're likely to get kidnapped. Somebody's going to take them, and so they don't have any sense of stranger danger. But again, all the result of trauma and lack of bonding. So again, genetically, we're all different how we react to trauma, and we have pathways in the brain. And apparently, when you're a baby, when you're a child, and you are subjected to trauma, it does cause changes in your chemistry and in your brain. So those are some things that we have to think about.
TIC.
Mm-hmm.
It's like the buzzword.
Yes.
Now. There are entire conferences on it.
Yep.
And actually, when you say trauma,
yep.
When you're talking about people, not just even children, but the trauma is defined as a divorced parent.
Sure.
A parent who was medicated for a psychological illness.
Mm-hmm.
So it's not trauma like I'm bleeding and something is...
Right.
But you can actually take a score, when you're given a score, and that determines what level of trauma, and then you actually program differently for that.
Mm-hmm.
But it does exactly what you're saying. How
Yeah.
when people are exposed to trauma in their life, defined in a different way than we as nurses think trauma is defined,
Right.
how that changes people.
Right. So even growing up with a parent that has a mental illness
Absolutely.
can be extremely traumatic to that child. It can make the home environment very chaotic. Yeah, and actually I've had students tell me that they've had their parent is either bipolar or their parent has had schizophrenia. Extremely difficult. I mean, they still have very painful memories sometimes of childhood. So, all right. Let's see here. Yeah, all different kinds of theories again. Okay. All right, we always go through the nursing process. So stages of intervention. So first stage usually is provide safety and stabilization. So if you ever have any questions, either on your NCLEX or exam questions, we always have to think about providing safety as being, in mental health, the highest level of intervention. And usually safety for us is not falling out of bed, having your side rails, call light in place. It's not those types of things. It's more psychological safety and certainly self-harm and suicide, preventing those. Because people that do have trauma-related disorders certainly are at high risk for suicide. So safety and stabilization, reduce the arousal and regulate their emotions through reducing their symptoms. And, as a child, try to catch them up then on developmental and social skills. Very, very important. So establishing trust and safety, developmentally appropriate language, relaxation techniques, art and play is so helpful for kids. Do you ever see that in the schools, Kelly?
Absolutely.
Okay.
I was just thinking we would have, like, if the child were in crisis, we had E-teams in high school, and so they would call over the PA system, E-team to the location where a student was having a meltdown. And we all had a role in that process. But and then the child was usually brought back into their emotional disability resource room, and then there were swings, there were trampolines, there were a lot of gross motor equipment, because a lot of times students choose that as opposed to Play-Doh or coloring. They needed a higher level of intervention. And so there really wasn't any processing or anything going on at that moment. The student was just moved into a situation where they felt like they could be in control and could calm down a little bit, because like you said, you can't educate or de-escalate when they're at that level.
Right. Okay, great. I really like having you here, because it's just kind of, you have some nice examples.
Teachers would think, well, he just misbehaved, and now you took him and let him go swing?
Oh, okay.
Why is he being rewarded for swinging? So there was a whole level.
Interesting.
Those EBD teachers really had to work hard and had to say,
that.
Because it's very misinterpreted what's happening with that process. But that EBD teacher knows that's what that kid needs.
Yes. Yeah, interesting that they would perceive that they're getting like a reward. Instead of, and maybe they think they should be punished,
they should sit here and learn that math instead of swinging like they want to.
Yeah. That's great that they have all those types of things available. Wow.
It's amazing.
Interesting. Yeah, interesting.
School looks really different now.
I'll bet it does. Okay, so involve the caretakers unless they're the cause of the trauma. So educate the child and caretakers about the grief process if that's appropriate, because perhaps there's maybe something happened in the family in terms of a loss or even a divorce situation, some kind of change in the family. So grief isn't just for death. Grief can also be maybe the parents are divorced and the mom is moving far away, and then that's a loss of that relationship. So any kind of loss, you might need to go through that grief process and assist the caretakers in resolving their personal distress and coordinate with social work for protection. So if child protective needed to be involved. So in case of child abuse or neglect, we certainly always need to involve them. So in adults, the main symptom is re-experiencing the trauma. Did anybody watch a movie on PTSD by any chance for your movie project? You guys did? Okay. All right. So how was in the movie? I'll pick on you then. How in the movie that you watched? How did how was the re-experiencing of the trauma? What was that like for you, the main character?
Just like flashback in like either dreams or like he would just do it if something triggered him.
Ah, okay.
Would, like, see, like, even just like a breathing or something.
Okay.
He would, like, see that person.
Okay.
Or the situation they were put in.
Okay. So he would re-experience that it sounds like a couple of different ways. Okay. So avoidance, did that person avoid stimuli associated with the trauma? Did they avoid wherever that, what do you know what was the trauma?
He was a prisoner of war.
A prisoner of war. Oh, okay. So maybe that's a little bit different then, as far as avoiding stimuli. Well, that could be right.
Enclosed spaces or anything
Yeah.
like that. Did you notice that those things were upsetting to him then?
Okay. All right. Because sometimes if, like, say if somebody is mugged in a parking lot, they will avoid parking lots as much as they can. You know, they'll avoid, or something happened to them in a park. I actually know a medical student, when I was in Rochester, a medical student was telling us that she was raped in a park that's near the hospital. She was jogging alone in the park, and she kind of dissociated during which we're going to talk about eventually. She kind of dissociated during the rape, and she said all of a sudden she kind of came to and she heard somebody screaming. She didn't realize it was her that was screaming. So then for a long time after that, she just totally avoided any kind of a park situation. It was just, so you avoid sometimes things that associate. But Kelly had a good point, because sometimes then people will avoid like fireworks and things like that loud noises, something that might kind of bring back some of those memories. Because fireworks and other types of explosive type sounds can bring back war memories, especially if they were, in active combat. So they have persistent symptoms of increased arousal. So they have like an increased startle reflex. You can't sneak up on somebody and just call their name softly. They're going to jump. They're going to jump a mile. And they are just more like anxious and on edge more than usual, and they could have some alterations in mood. It's funny because my dad was in World War II, and I never really thought about, he didn't really talk about the war much, and I think he just really didn't want to talk about it much. But it's funny because I never really put it together until a few years ago that I'm sure he had PTSD. So I made sure that when he went into the nursing home that they knew that he had, I diagnosed him myself, that he had PTSD, because I just always remember him, just as a kid, I just remember him always startling and jumping a mile if you came into the room and he didn't hear you come in. And just certain triggers for him. My mom could never make casseroles for dinner. And I think because casseroles for him is like, casseroles, everything kind of mixed together. And I think that was nauseating to him. I'm sure it reminded him of vomit. Okay.
Probably what they were fed.
Or it could be, yes, what they were fed, and then just, yeah. So certain things now, as I look back, are like, So people experience, in different ways, but it's very common in people that have been in wars, especially, to think about them having PTSD. And of course, in those days, you didn't really get treatment. Most people didn't get treatment. They just kind of carried on with their lives. Just think about all those people in the Holocaust that survived that. They all have PTSD. Most of them did not get treatment. They moved to the United States, many of them from Europe, and they just got remarried, had a new family, and started their lives over again. And just so, which just reminds me of my last job that I had in Rochester before I moved here to Wisconsin. I worked in a Jewish nursing home, and many of the people there were Holocaust survivors, and they still had their number tattooed, on their arm, whatever their prisoner number. And I remember having to do a lot of reading through their histories, and then having to do a lot of teaching and reinforcement with the staff, because they would, like Kelly, like your teachers would say, like, why do we have to bother with this, whatever. They would be like, well, that was so long ago, that shouldn't be affecting their behavior now, and they should be over it by now. No, you don't get over that.
And that is, I chaperoned my daughter's trip to Washington, D.C., and we went to the Holocaust Museum.
Oh, okay.
Which I would recommend to anyone. Has anyone else ever been there? Mm-hmm. And when you hear those when you watch those videos, and the cards of what those people were, I remember thinking that is PTSD.
Oh,
like,
absolutely.
People these days think they have PTSD. Try and live after you survive that.
Right.
Those stories are horrific, aren't they? And those cards.
Yep.
The card that they give you in the beginning is like based on one person.
Oh, okay.
You go through the whole thing, and then in the end you find out if they survived.
Oh, really? Oh, wow.
An identity. Yes, you're supposed to be the person
how
going
interesting.
to the museum, and then you find out
Wow.
if you survive or not. And
Oh my
I don't recommend
gosh.
it to anyone, but even when
Wow.
you're done, you are just heavy. There's even a processing room about what you kind of just a
Oh my
safe
gosh.
space before you have to leave. It's
Wow.
phenomenal. It was really.
Oh, when I was there some years ago, we couldn't get in because they were booked, so we couldn't get in. We should have made reservations a lot sooner. So the next time I go there, I will for sure. But I just remember reading their histories, and it's like they saw all their family members shot, in front of them, their husband, their wives, their children. And then again, like I said, they survived. They moved to the United States, got remarried, got more children, carried on with their lives. It was really interesting. So I did a lot of teaching with, no, you don't just get over it. It's going to affect your mood, your behavior, even if you're an older person in a nursing home, So, yeah. Okay. All right, so we really want to help to manage their anxiety, increase their self-esteem, improve their ability to cope. So we're doing, pretty much same interventions for adults and children. Medication, there's no specific medication, of course, for PTSD, but if they have anxiety, depressive symptoms, we're going to treat those with the appropriate medications. There is something called EMDR therapy, and I just read a lot of different conflicting reports on if that's helpful or not. Eye movement and deep, I knew I was going to forget that word. Eye movement, something reprocessing. I can't think of what the D stands for. Anyways, it's not on the test, but I just can't think of what that is. But it has to do with like your eye movements, and the therapist is having you move your eye in a certain direction, and they are doing different types of therapy while they're having you move your eyes in different directions. And I just read some reports. Thank you. I just couldn't think of that word. Eye movement desensitization, reprocessing, right? I think, yeah. Thank you. Okay, thank you. But anyways, reprocessing, yes. So anyway, so they're trying to help them somehow through the eye movements and the therapy to kind of come to terms with what happened and to experience decreased symptoms. Some people swear on this, and this is a great therapy, and I've read other articles that say it just isn't really.
Have your eyes with you. That would be one nice thing.
So I know it's just I've just read some articles that say it's just really not very effective. Okay, so acute stress disorder is something that can happen immediately after a traumatic event and can persist for a couple of days. And usually it resolves in about a month or so, or it could become PTSD. So it could become, sometimes you might have just a very stressful traumatic situation. It's not necessarily always going to become PTSD. So there is something called acute stress disorder. Adjustment disorder is another type of trauma-related, and I don't see this diagnosed very often anymore. I used to see it diagnosed a lot in the 80s and 90s, but I'm guessing, I'm just going to take an educated guess that it still exists, but insurance companies maybe won't pay for this, for hospitalization. Because sometimes people with this, they can really have very serious acute symptoms. But because it's not major depression or a specific anxiety disorder or a substance abuse disorder or schizophrenia or bipolar, that they don't pay for it, because supposedly an adjustment disorder, you should just be able to get outpatient therapy and be just fine. But some people do need hospitalization. I'm just guessing that's why I don't see patients diagnosed with this very much. But anyways, it's again precipitated by a stressful event, and they're just temporarily really debilitated, cognitive, emotional, behavioral problems that impact their functioning. So it could be a combination of depression, anxiety, and some disturbances in their behavior. And it's, again, usually just related to a certain type of stressful event, any type of stressful event. Dissociative disorders occur after significant traumas. And people that dissociate have severe interruptions of consciousness. And dissociation is an unconscious defense mechanism. So like the example I gave you of the medical student said that basically she pretty much sounds like she dissociated during that episode, and that she, again, heard somebody screaming and she didn't even realize it was herself screaming. So it is something that happens like that we're not quite aware of, and it does protect us from overwhelming anxiety through emotional separation. So if somebody dissociates over and over and over again because they have so much trauma in their life, many times they actually develop dissociative identity disorder. And we used to call that multiple personality. So now it's called dissociative identity. And the people that I've taken care of that have that disorder have had such horrible, horrible trauma that it's almost unbelievable. Have you ever read any books about people that have
Sybil in high school?
Okay.
That was
Yes.
intense one. She had like 13
Yep.
personalities.
Yeah, that'd be a really good example. Mm-hmm. Anybody else read anything about people that have had like horrible trauma? I think there's one called, I can't remember the exact name of the book, but The Boy Called It. Something like that. I've kind of heard of that. Actually, though, I don't think that he developed that disorder, but if you read that book, the stuff that he went through, you would think that he would have developed dissociative identity. Absolutely. I mean, his mother made him eat feces and just horrible things that you just can't even imagine. Were you going to say something?
I think I read that back in a
Long time ago? Okay. Yeah, he had just like chronic, unrelenting abuse from his mother. And his mother actually never even got, I don't think, his mother even ever like went to jail or anything. It was I think it was back in the 70s when that happened.
I remember like her burning his hand on the stove.
Yes,
Like that.
yes, right. So, yeah, just usually really horrible things. I took care of somebody once who had a dissociative disorder. Well, actually a couple of people, but this one in particular, she had some of her personalities were male, some were female, some were young, some were older. It was really quite interesting. But her one of her horrific experiences was her dad would, as a little girl, her dad would take her hunting with him. And then, like, he'd get a deer, and then he would gut out the deer, whatever you do. I don't think I could ever do that. And then he would make her ride home inside the deer, like in the deer carcass, in the trunk. Yeah. Horrible, horrible, horrible abuse that this poor person went through. And, I could tell you other examples, but they're so gross I can't even talk about them. So we're not talking about, getting a little, physical, just hitting or, that's bad too. But we're talking about like really sickening, horrible things that happen to people. So, of course, then we need to somehow dissociate to protect ourselves, right? We might have little episodes of dissociating, just like, I just remember being on a whale watch a few years ago, and I get seasick. I just don't like boats or anything at all. So I don't know why I got talked into going on a whale watch out in Maine, I think it was. So anyway, I took some Dramamine. I made all of us, my whole family took Dramamine, so we were fine, but everybody else wasn't. So everyone's puking, it was horrible. The weather was horrible, and I just remember just kind of like closing my eyes and trying to picture myself somewhere else because I just wasn't. So I was probably consciously trying to dissociate because I just didn't want to be there. It was so miserable. But anyways, until I saw my first whale, and then it was the coolest thing ever. But, yeah. So we do have a couple of different types of dissociative disorders. So depersonalization or derealization. So depersonalization, where you don't think you're real or you don't feel like you're real. Derealization, things around you seem like they're kind of fuzzy or not quite real. We have dissociative amnesia and dissociative identity disorder, which I was starting to describe a little bit to you. So again, environmental factors, usually very difficult aspects of your environment. There could be some cultural considerations, how people respond to different types of stressors. So again, depersonalization, yourself, derealization, focus on the world. Dissociative amnesia, I've seen a few people with this. They have the inability to recall personal information, so they kind of don't know who they are. They don't know that they're married. They don't know perhaps where their address is, if they work or not. And it's, again, a traumatic, stressful event happens. And they have amnesia. They don't remember things, and it's usually personal identity types of things. A dissociative fugue is kind of a subset of that, and they have, if they're in a fugue state, they could just get on a bus and just travel anywhere and just get off the bus, and they're somewhere where they don't even know where they are. They didn't plan on going there. They don't know anyone there. They just get off the bus and they don't know who they are. So it can be a really difficult situation. In my big pile of mess here, I do have an article somewhere. Maybe I'll try to find it during the break. About, oh wait, is this it? No, that's not it. Darn it. Okay. Anyways, I have a newspaper article that I cut out about a man who was in Texas, and he kind of had a fugue state, and he just kind of was wandering around. He didn't take a bus anywhere, but he was just kind of wandering around Dallas, I think, which is a pretty big city, which is quite far from his home. And they found his wife was putting up posters of him, you know, and all around the city, saying like, have you seen him? He's lost. And he didn't know where he was. He didn't know he was married. And they're not even sure. He lost a bunch of weight, but they're thinking he was probably going into the dumpster and he didn't have any money with him, going in the dumpster and eating that way. They found a couple of like jelly packets, you know, old jelly packets in his pocket and stuff like that. But they did find him because the wife had a picture of him and put up posters everywhere. So, and he has had those episodes before, and again, precipitated by a stressful event. So again, that dissociative identity, they have usually 2 or more distinct personalities. Andrea, you were saying that Sybil had about 13. Okay.
Would that happen like right after the event, or would that be like going to happen to like years after the event?
It's not going to happen usually years after. It's going to be pretty soon after. Yes. Anybody else read any other stories or hear about people that have dissociative identity, or what we used to call it multiple personality? Split. Yep. Yeah, I didn't see that one either. I've got to see more movies.
I don't really find out anything about his like past. There's coming out with another movie.
Okay.
Yeah, it's connected to the movie with the one where that guy survives that train crash and everyone else died and he's the only one that survived.
Oh, wow.
I don't know, but they're
okay.
But yes, Split is a really because
okay.
he has like a little kid personality. He has those 3 girls and the one girl he like befriends as the kid personality.
Okay. Yeah.
And then like he knows he's not like supposed to the little kid personality is supposed to like let her out of the room, but she convinces him, and then the different personalities take over and get mad at the little kid personality.
It is really interesting. And you know, some health professionals don't believe that this is a real diagnosis. And that actually persists even today. There are truly some people that don't, psychiatrists, psychologists, that don't believe it's a real diagnosis. So that makes it really difficult to treat, because if you don't think it's a real diagnosis, but honestly, I've worked with enough people that have this that I absolutely believe it's a real diagnosis. When you approach somebody and you can tell they are completely different from when you approached them an hour ago, and their voice is different. So I had one experience that was really rather kind of eerie, I guess would be the best way to put it. This young girl, she was in her 20s. She had some eating disorder issues, and she had long-standing history of like child abuse. So she was very much abused. So she had a dissociative identity. And she had a couple of different personalities, and most of her personalities were like, pretty okay. Some of them were a little bit more flamboyant, and some were quieter. And the host personality is usually like the main, the main person. So Lisa was the host personality. Well, one of her personalities, and they all communicate with each other too, which is kind of odd, but one of her personalities identified themselves as a witch. Okay, so one of the personalities was a witch. And Lisa would always complain when she was out. She would complain that the witch wanted to kill everybody And that's very typical, that one of the personalities is suicidal and murderous and wants to kill everyone. So I would always, when I had my talks with her, I would challenge her a little bit. And I said, well, because the witch wanted everybody dead because a certain thing was going to happen in the afterlife. So I would always challenge and say, how does she know that that's going to happen in the afterlife? I would just make some challenging kinds of statements. So one day, the witch came out and wanted to talk to me. That was scary because the witch had never talked to anyone else, ever. So I was really kind of privileged. But honestly, I had such anxiety when I went in there because I could tell that this person was like evil. You just felt it coming from her. You could feel a completely different demeanor, completely different voice, very serious, very angry. And it was like, oh my goodness, I am really talking to somebody else. I'm not talking to Lisa anymore. And then I don't remember, that was too long ago, I don't remember exactly, how the conversation went, but the witch wanted to talk to me because of my challenging her assumptions that what she was, expecting a particular thing to happen in the afterlife. And I remember even a few years later, her outpatient therapist called me down to her office because I was the only one that the witch had ever talked to. So she wanted to my recollection, and I had written a really long, good progress note that night too, so we were able to look back at my charting, because she was trying to help this girl to reintegrate back into one personality. So, very chaotic. Absolutely, it's very chaotic.
Sybil, she wasn't like her actual personality for like years. Like it was like 10 years before she came to
Yes.
with herself again.
Yep.
She had lived her life as all these different personalities that she didn't
Yep.
know about.
Yep.
That was insane.
Yeah, it really is. And it really does happen. So I've worked with, again, several people that have this. Another really good book, if you're ever interested, I know you don't have time now because you're in school, but there's a really good book, and I don't remember the name of the author, but it's called The Flock. So like a flock of geese or whatever. It's called The Flock. Fascinating. She talks about going to college, and I forgot how many personalities she had. I think it might have been like around 20 or so, with quite a few personalities. And again, some were young, some were old, some were male, some were female, some were homosexual, some were heterosexual. So it was really an interesting mix of different personalities. But she went to college, and two of the different personalities were out kind of at the same time. One was taking notes with her right hand, and the other was taking notes with the left hand at the same time during class. So if you guys ever do that, I'll be like really worried. No, I'm just kidding. But it was interesting because the one personality would say to the other, stop. People are going to be looking, because literally one was taking notes with the right hand and the other was taking notes with the left hand at the same time. Yeah. So anyway, that's a fascinating book.
True. I mean, how could you do that?
Right.
Could
Exactly.
make that up.
Right. You can't make it up. That's exactly right. And it does take years and years and years, like 10 years you were saying?
Yeah, I think it was a long time.
I think that's pretty typical, that it takes a really long time of intensive therapy to help people to reintegrate back into that one personality. So anyways, just think about your impact on your daily life and people around you, especially if you, because some of the personalities might be more flamboyant. They might dress really provocatively or use a lot of makeup or whatever, and some other personalities might be more quiet and shy. So just think about the things that you can get into, the trouble you can get into when you are maybe more provocative. So suicide risk is huge, because literally almost every single person I've cared for that has this disorder, at least one of the personalities is suicidal. And so if one personality is suicidal, if that person is out at the time, then the risk of suicide is very high. And again, that self-assessment is, we always have to look at our attitude and our feeling, and do we think that this is real or not real? And of course it is real, but we might think, they're faking it, they're putting it on. And if we have those types of attitudes, we're not going to be very therapeutic. So we really need to help people work through their things and establish, again, integrity of their whole personality. That's the goal. So Medication, again, there's no specific medication for dissociative personality, but we may treat them with an antipsychotic to bring down their extreme levels of anxiety. Antidepressants, so we're treating their symptoms, but there is no specific. Okay, and again, advanced practice interventions. A nurse assesses a patient diagnosed with a dissociative identity, which finding would be part of the patient's history. Travel to a foreign country, physical or sexual abuse, thyroid dysfunction, or an eating disorder. Physical or sexual abuse. But you know, sometimes an eating disorder does go hand in hand, like that one person I told you about with the witch personality. She also had an eating disorder too, in addition to her other depression, anxiety, illnesses. Alrighty. Okay, so now we're talking about somatic symptom disorders, SSDs. Don't remember that. We have too many initials, don't we? I can't remember them all. Just say what it is. That's kind of how I feel. Anytime I see that, I'm like, what is that disease? So anyways, case study. Mr. Brazelli, I didn't make these names up, is brought to the emergency department by a cab driver who walks with him into the entrance and says, "This guy says he just lost his sight. He just went blind after he got into my cab." Mr. Brazelli is very patient and says during the assessment, "Well, I've had several episodes like this. I guess this just happens sometimes." So again, this is another really interesting. Have you ever heard of this or seen anybody with this? With this is a conversion disorder. It's one of the somatic symptoms. Have you ever seen anybody or heard of a conversion disorder? Sometimes you might see people like this in med-surg. Because they're usually, if it's something serious like losing your sight, losing your vision, losing your ability to walk, having a pseudo-seizure, you're probably going to get a good physical workup first. So, you haven't seen anybody. No? All right, well, I do have a story to tell you, but I think I'll just wait a little bit. We'll just talk about kind of what this is first. But I have a really interesting story about a girl that I went to college with and ended up on the mental health unit where I work, and she had a conversion disorder. So anyways, somatization in general. So somatization is expression of stress through physical symptoms. Okay? So the physical symptoms don't have a physical basis, but they are brought on by stress. Okay? And their symptoms are expressed in place of anxiety, depression, or irritability. So we do have to have a holistic approach because we do need to kind of look at the whole person, and we always want to make sure that there isn't something physical going on. So actually in clinical last week, we had a patient who was a middle-aged man, and he was having a lot of somatic symptoms. He would constantly complain that his bowels weren't working and that he was constipated, terribly constipated, and he wasn't urinating enough. Okay, those are kind of his two biggest focuses. And it was interesting because I have a lifespan group there right now, so the student kind of in post-conference said, when he voided, he voided like 1,400 cc's. That's like a lot of urine. But he said he wasn't voiding. So it was kind of cool to see that she was able to make the connection between the reality and his perception. So his perception was he wasn't voiding enough, and she's like, but I measured 1,400 cc's. That's a lot of urine, right? So, and then she also noted that in his chart, he was having a bowel movement every day. So he wasn't constipated. He was having perfectly normal bowel movements, but his somatization, his expression of his anxiety was that he couldn't have a bowel movement. He was totally bowel focused. You know, our older people sometimes get that way in the nursing home, right? Everybody gets kind of bowel focused. Well, but in this disorder, this guy was only, he's in his 50s and in pretty good physical shape. There was no reason for him to have these problems, but they weren't real. They actually weren't real. So, very interesting. All right, so we have a couple different disorders we're going to talk about. So somatic symptom disorder, illness, anxiety disorder, and I will have a little video to show you two of that. Conversion, psychological factors affecting a medical condition, and factitious disorder. So we're going to kind of go through these. These are really quite interesting. So during assessment, Mr. Brizelli says that when these episodes of blindness come over him, it's often immediately after an epileptic fit. However, he doesn't have any signs of having a seizure. So they probably did an EEG. Didn't see any evidence of seizure. So the ED physician records that he has neurologic symptoms, but in the absence of a neurologic diagnosis. All right, so that would be really the hallmark of this. He also makes note of his patient's lack of distress about what should be an alarming condition. Okay, so the example I have is this girl that went to the same college I did. It was a very small campus, so everybody knew everyone. She wasn't a nursing major. I forgot what she was majoring in. But I remember seeing her on campus, and I didn't really know her, but she was very bubbly, very loud, kind of social kind of person. That's what I remembered of her. So she came onto the unit, and she was in her 20s. She was in a wheelchair. And she didn't seem to really care that she was in a wheelchair. You know, she's in her 20s, right? Would you care if you were in a wheelchair? Like all of a sudden? Like, wouldn't you be kind of, right? You would think that you'd be a little bit alarmed about that. So she was in a wheelchair, and I remember she was admitted, and she was just wheeling herself all over the unit and ordering pizza on the phone and socializing with other people. And I'm kind of scratching my head because I don't think I'd ever seen a conversion disorder before. And, you know, we're all kind of scratching our head like, but that's basically what they do. So do you know why? Why would somebody get a physical symptom like that? What do you think is underlying all that? Why would you get a physical symptom as a result of your stress? Like, what does it do for you to have that physical symptom? Maybe I'm not asking the question right.
You avoid the anxiety.
Oh, there you go. Yeah, you kind of hit the nail on the head. So it kind of takes all your anxiety and it binds it all up in that symptom, in that physical symptom. So now you don't have that anxiety. Okay? Yeah, very good. So it kind of takes care of it for you. So, all right. So, somatic symptom disorder then is having one or more distressing symptoms. So sometimes people have multiple types of complaints. And sometimes their complaints are pain. They could be complaining of tremendous amounts of pain. They could have different types of physical sensations. Again, like that man with the constipation. He felt like he was constipated. He wasn't urinating enough. And I think he had a couple of other somatic complaints too. So one or more distressing symptoms, excessive thoughts and anxiety behaviors around those symptoms or health concerns. And he was constantly talking to us about that. So what do you think that the student did for this person? Do you think that she overly focused on his physical complaints, or did we try to get him to do other stuff? You know, was it therapeutic? Would it have been therapeutic for her to feed into that? No. So what she did was try to get him to go to groups because he wasn't going to groups. And actually, we see as students, you guys do miraculous things sometimes. He wasn't going to groups, and the student was able to get him to go to groups and get him to focus off of that, you know, all those symptoms that he thought that he had. So we don't want to feed into those. We don't want to be overly attentive to those symptoms. We don't want to give them too much attention around that. Of course, we have to do a little bit, you know, we have to do some assessment because we want to make sure they don't have a real problem. So their suffering is authentic. I mean, this guy really was suffering. He really, really thought that, you know, really believed that he was having all these terrible things happening to him. And they do have a high level of functional impairment. It was affecting his marriage. It was affecting his job. Matter of fact, I don't remember if he lost his job or he was like kind of on the verge of losing his job. But anyways, so we do have to take these disorders seriously. All right, I'm going to stop here and give you guys a break because then I'm going to have a little video to show you about illness anxiety disorder. So we will take. So that was kind of a humorous, you know, the video is done a little bit humorously, but what points did you get out of that? So that'll help you just really to understand some of the symptoms. So what points did you get out of that little video clip?
In his mind, he really has cancer.
Yes.
He really has
Yep.
all these things.
Right. He truly believes that he has those serious illnesses, right?
Perseveration of thought, just constantly, you can tell
Yep.
how he wasn't
Yep.
productive with his ADLs
Right.
at all.
Yep. Anything else? Okay, how about that first word? Misinterpretation. So what misinterpretations did he have? Yes. They misinterpret things that are normal and feel that there's something serious and that they're cancer or, something else real serious. Yes. So they misinterpret normal things. If they do have anything, a real illness going on, usually it's something that's very mild. Like maybe they have a cold. Maybe they have the common cold and they think they have pneumonia. So there could be something minor physical going on, but usually it isn't the major thing that they think of that it is. And they're just really preoccupied. Like Kelly was saying, just that constant thought process. They're just preoccupied. Symptoms have to be there for at least 6 months. High anxiety, excessive health-related behaviors, what was he doing? What were his health-related behaviors? Think about his phone calls, right? Calling different doctors, trying to make doctor's appointments. Or sometimes people have maladaptive avoidance of going to seek health care. So they may be care seeking or care avoidant, but I think most people seem to be health seeking. The problem with this is what did he do by the end of the video? He got an appointment with a different doctor. So what do we call that? Is there a word for sometimes when people are seeking multiple healthcare providers? Like doctor shopping, right? So that's very common. They'll go to one person, they don't like what they hear, they're going to go to another person, and then they're going to go to another person because they didn't like what they heard. Or another specialist. So maybe they're going to see 4 or 5 different people, and is that good for overall health care and continuity of care? Because nobody ever gets to know them. They don't develop a relationship, a rapport with a particular provider, okay, that can actually kind of help them to work through this. So it's more beneficial for them to have one person that they go see on a consistent basis, rather than doctor shopping and going to multiple providers.
It's difficult for the patient because these days one doctor doesn't really take care of multi-systems. So they're referred based upon their symptom to a specialist. But
Yep.
There should still be a primary care practitioner that's coordinating
Right.
all of that care. But it's
Right.
I feel it's difficult for the patient too, because if they go in with complaints of a respiratory type issue, they may be referred to a respiratory specialist.
Sure.
So it's difficult for them as well, because really no one doctor manages.
Yeah.
I mean,
There are internists around, but like the day of the old family doctor is kind of long gone. So
so it's confusing for your patients too, and then you need to bring them back to the center
yes,
of
yes, definitely. Okay, so then that conversion disorder again, just talking a little bit more about that. So usually they have deficits in motor or sensory function. So the common symptoms then would be paralyzed, like that girl who I told you about that I went to college with. She couldn't walk. Well, there was no reason for her not to be able to walk, so she was paralyzed. She was in a wheelchair, but she had no physical problem that was causing that symptom. Blindness, deafness, numbness, paresthesias, so loss of vision or hearing, or episodes resembling epilepsy or pseudo-seizures. Have you ever heard or seen anybody have a pseudo-seizure? No? Kids ever have any of those?
diagnosis, but I haven't ever really seen.
You haven't seen them. Okay. We've had a few people on 1K have pseudo-seizures, and it does look like they're having a real seizure. So we do need to make sure that we know the difference between a pseudo-seizure and a real seizure. So do you know how you might tell the difference between a seizure and a pseudo-seizure? You must have had seizures at this, not you've had seizures. Learned about seizures at some point or not quite yet?
would be like the level of
in your child.
consciousness of the person during the event.
Mm-hmm. Mm-hmm. Yep. That's part of it. Anything else? Have you had much about seizures yet or not really?
I don't remember talking about pseudo seizures.
Okay, do you remember talking about real seizures ever in any of your classes so far? Kind of? Okay. Okay. So the level of consciousness, that has a lot to do with it. So they can look like they're not with you. They can look like they're really quite out of it. But if they're laying on the ground and they're having what looks like a seizure, if they really were having a real seizure, they would not be able to respond to anything. So if you pick up their arm and you let it drop, if they're having a pseudo seizure, they're going to protect, and they're not going to let their arm hit themselves in the face. They're going to make sure their arm goes to their side. If they're having a pseudo seizure and if they're laying down there and you lift up their arm, if they're having a real seizure, their arm is just going to flop wherever, and they could end up hitting themselves in their face. Okay, so that's one way to tell. Another way that we used to do, which I don't know if that's something that would be like recommended, but we used to have ammonia capsules on the unit. Have you ever smelled ammonia? You know what ammonia smells like? It's like really bad. So you break an ammonia capsule and you hold it up to their nose. If they're having a real seizure, they are not going to respond to that, right? They are out of it. That's their level of consciousness is not there. It is really low. They're not going to respond to it. But if they're having a pseudo seizure, they're going to be pulling back because it smells so obnoxious. So their level of consciousness is not going to be as impaired as it would be, but they're going to look like they're impaired until you kind of test it out a little bit. But there are some people that are really good at pseudo seizures, and they really look like a seizure. So of course, we would recommend and make sure that the doctor ordered for them to have an EEG, just to make sure they don't really have a seizure disorder, because sometimes people have pseudo seizures and real seizures going on at the same time. So then it's hard to tell. Really is hard to tell if the episode is real or if it's not real. But anyways, all right. Yeah, so they're usually some sensory in nature. And that labelle indifférence is that French word that kind of means that they don't have any distress. They're indifferent. So this girl's whipping herself around in the unit, ordering pizza, socializing, and she's in her 20s and she can't walk. She's wheelchair bound. You'd think that she'd be concerned about that. But they're not, because as Andrea was saying before, it kind of like, it ties up all their anxiety into that symptom, and now they don't have to feel that anxiety. So it really is kind of an interesting phenomenon to happen. So psychological factors do increase the risk for medical diseases, magnify them, or interfere with their treatment. So, you're going to see people in the med-surg unit that have maybe increased symptoms because of their because of stress, right? Or depression too. Depression can cause people to not come around as quickly, not become healthier because of the effects of that on their physical illness. So, anybody have any examples that you've seen in clinical? People that have had maybe depression or anxiety and they're just not kind of coming around as quickly as they would be, or maybe their discharge is delayed because of having a stress or depression as a result of their illness. Yeah.
I just had a patient, she lost her daughter, I don't even know how long ago, but it was
Okay.
recent. And they had to keep her because they wanted to say consult on her.
Okay.
So she couldn't leave, and every time, she loved taking walks. So every time I took her out for a walk,
Okay.
we'd get to one of the windows and she'd just start crying about how much she missed home.
Oh, okay.
And then the last day I had her, she was crying because she was happy because she could go home tomorrow and she had to talk to her grandson.
Okay.
You could definitely tell there was something, she had some mental disorder.
Mm-hmm.
But the psychiatrist just saw her. But,
Okay.
so I never
Okay.
found out what she actually had or what they ended up doing with her.
Okay. So if you have a psychological problem as related to your physical illness, it can delay your discharge. It can make your treatment go on much more than that, and it's too bad that she didn't maybe get a psych consult, because perhaps she could have, that could have been very helpful for her. All right. So, which diagnosis then best describes Mr. Brazelli's condition? So remember, he had the problem with, I don't remember now, was it his sight? He got into the cab and he lost his vision. Okay, so that would be which? Hopefully D, right? Conversion disorder. Okay, so we're always going to assess people's coping skills, perhaps their spirituality that might influence how they're coping. If they're getting secondary gains. So, anybody know what secondary gains means? Secondary gains is like the goodies that you get from being sick. So what kind of goodies do we get when we're sick? Attention. Anything else?
People sometimes bring you gifts or presents or flowers.
Yep. You get
cards,
presents, you get cards.
phone calls.
Mm-hmm. Might get some nice positive things from people, some positive attention. What else?
Off of work.
There you go. You get out.
Off of school.
You get out of things that you normally have to do. So you might get out of schoolwork. You might get out of an exam. So you might get an exam delayed because you can't take it because you're sick right now. You might get something else. Somebody else might have to take over some duties that you have that maybe you don't really like to do anyways. So perhaps if you have a spouse, significant other, and all of a sudden then you don't have to cut the lawn anymore, and you don't like cutting the lawn anyways. Now, you can't, so that other person has to do it, yes. Or doing the bills, whatever, cooking or cleaning. So anything that you can get out of is also a secondary gain. In addition to then the positive things that you might get, positive attention, people are nice to you, they give you gifts, they call you, they might make you a meal. So that's what we're thinking about secondary gains. So sometimes we do have to look at that if people are getting secondary gains from their psychological illness, symptom disorder, whatever. So cognitive style, just their style of coping and relating, their ability to communicate. Because if you think about it, if their anxiety symptoms are all bound up in all these physical symptoms, they most likely are not able to communicate and talk about their anxiety and talk about their feelings. So that can be a very helpful thing for patients. And the gentleman that we took care of this past week, the one who was very somatic and thought he was, his focused on his bowels and his bladder especially, once he started going to group, he actually started talking more about his feelings. And so that, hopefully he'll continue that, and he was already there for like 3 weeks, which is a really long admission. He just wasn't getting better, but he's starting to make a little bit of progress now. We want to look at if they become dependent on medication, because they may actually, the other thing that happens sometimes, you're going to all these different specialists, and there are times when we get things prescribed that maybe they don't necessarily need. Like they'll go to the doctor and they'll end up getting an antibiotic. Right, I've seen that happen sometimes. People get prescribed things just because, okay, they may not have a valid reason, but sometimes I think maybe they just are trying to maybe help them feel better, but not really understanding the actual illness. So people can get dependent on taking different types of medication, and I'm not just talking about things that are actually addictive. And again, self-assessment, because people can be very frustrating. They don't necessarily stick around long enough for you to have develop a relationship with in order to be helpful to them. And sometimes we might just think they're trying to get attention, or we may just get really frustrated with working with people like that. So these are just some different types of diagnoses used with these disorders. So pain, anxiety, and ineffective coping, social isolation, risk for suicide we always have to think about. And we always want to make our goals with the patient, and hopefully setting very small goals, one step at a time, so they can see some progress. And again, always get that therapeutic relationship, and groups is very important. Effective coping, focusing on their strengths is really important. everyone has strengths. So 6 key elements provide continuity of care. In other words, that doctor shopping thing isn't real helpful. So try to get some continuity of care. Avoid unnecessary procedures. And to me, I would throw in avoid unnecessary medications too. It really isn't helpful if the doctor just thinks, oh, I'll give them an antibiotic just to kind of, keep them quiet or pacify them. That's really not a very effective thing to do. Brief, regular visits. Always conduct a physical exam because we do want to make sure that there isn't something physical going on. Avoid disparaging comments and set reasonable therapeutic goals. All right. So social interventions, psychosocial interventions, coping strategies, self-care. This gentleman also wasn't doing much with his self-care. He wasn't showering very frequently, changing his clothes, things like that. So we always have to make sure we focus on those things. Medication, again, teaching. Okay. Advanced practice. Okay, I don't have anything else to add on there. Evaluation, realistic, measurable outcomes. Okay, factitious disorder. So these are the last disorders we're going to be talking about. So, have you ever heard of Munchausen's? I'm guessing you've heard of Munchausen's, right? A couple of people? Okay. So, do you ever see anybody with...
Oh, yeah.
Oh my, okay, you do. Interesting. Okay.
Parents in particular.
Ah.
I mean, suspicious.
Okay, so...
I can't say it's been clinically diagnosed.
Okay, so you're thinking, is it Munchausen's by proxy
Yes.
then? The things they're doing to their children?
Yes.
Ah, so factitious disorder is artificially, deliberately, and dramatically fabricating symptoms or self-inflict injury. So if it's themselves, if they're doing it to themselves, it's Munchausen's. If they're doing it to somebody else, typically a child, it's Munchausen's by proxy, which, by the way, is a form of child abuse. So do you guys end up having to report those if you're suspecting the parent is tampering? Do you get into reporting that? Or?
No, it's so complicated because by the time, like the parent is just kind of doctor shopping to try to get so many different opinions and following through with the appointments and getting the results of the appointments. I mean, they even switch schools, they switch districts, they come back to your district. So by the time you get to a level where Child Protective Services would really have the correct information to do something about it, it takes such a long amount of time.
Oh, wow, that's interesting.
And then you're focusing your efforts a little bit more so on, psychological treatment for the child or the parent. The child is what we focus on. It's so complicated.
Yeah. Oh, interesting. I didn't realize that there would be that much like moving around to different. Okay. So, for Munchausen's, when you're self-inflicting injury, anybody ever heard of any examples of people doing this? What do people do to create injury on themselves? And the goal is assuming the sick role then. Now, they're in the sick role. People have to take care of them, so they get all kinds of goodies, secondary gains from being a patient, from being taken care of, being nurtured. So any examples that you can think of?
Like cut for attention, like that.
Okay. All right. Anything else? When I did med-surg clinical, a long time ago, I used to do med-surg clinical, and there was a husband and wife who would alternate coming in to the hospital on a med-surg unit, and they would inject themselves with using dirty needles. They would inject themselves with saline using dirty needles. And so, of course, then they're going to develop cellulitis, infection. Yes. So then they would come into the hospital. So sometimes, usually be one at a time. So the wife would come in. She would have injected herself with dirty needles, and she'd get cellulitis. She'd be on IV antibiotics. Okay. She'd be there for 4 or 5 days. Get better, go home. Next thing you know, her husband would be admitted. Same exact thing. So they both had Munchausen's, and they both alternated coming into the hospital to get rescued and taken care of by healthcare professionals. So the goal is assuming the sick role, and it is kind of a compulsive behavior. So there's a compulsivity to that. They are doing this kind of on a continuous basis. So when you do it on somebody else, like a child, then it's basically it is child abuse. So sometimes parents do things like give their child, I don't even know if they sell it anymore, Ipecac. Do they even sell that anymore? Do you know what that is? We don't use that medically at all, and it is not recommended to keep in your medicine cabinet like it used to be. In the old days, everybody had to have Ipecac in the medicine cabinet for your children in case they ever swallowed something they shouldn't, and then you can give it that, make them throw it up. It's not even used, I don't think, in emergency rooms anymore. They don't give it to people if they overdose or something like that. So they would give their child Ipecac to make them throw up. They would give them copious amounts of medicine to make them have like diarrhea. What else do they do? Think of other things that they can do all kinds of things to tamper with their child and bring them to the emergency room so they get treatment. Parents have even been known to give their children something to cause them either to have vomiting or diarrhea when they're in the hospital. They'll sneak it to them when they're in the hospital. I've heard of situations like that. So, yes. So that's factitious disorder, which is Munchausen's. Malingering is kind of related to that. When you have malingering, you could possibly have something real going on, but have you ever heard of the situation or the phrase called like milking it for all it's worth? Do you know what that means? Right? So you might have something real going on, but it's better, but you're milking it for all it's worth, and you're going to continue to try to get out of things that you should be doing and try to get some attention, try to get people to take over doing things for you. Because really you could be doing it, but you say like that you can't. Okay? So I'll give an example. I tried malingering when I broke my foot several years ago, and it was hard to do things, but even when my foot got better and I was off my crutches and all that, I would still be like, oh, I can't make dinner tonight, my foot. Oh, I can't do laundry. Just hoping somebody else would do it. No, it didn't work very well. But anyways, so there might be something real going on, but it's not to that point anymore where you can't function, and you try to get people to do things for you. So that's kind of what malingering is. Okay. So again, we have to really determine if those symptoms are conscious, unconscious. We don't want to confront people directly about these, but we do want to try to try to help them work through their anxiety. Planning and implementation, monitor for safety. Of course, that's huge, especially if people are doing things to harm themselves or harm somebody else, because truly Munchausen is self-harm. We want to teach them new coping strategies because that's not a very effective coping strategy. So an example of malingering, Mr. Harris injures his foot to avoid military service. Mrs. Adams has been making her child vomit and lose weight to pretend he has cancer. Mr. Singleton has difficulty walking, uses a wheelchair, but without neurologic deficits. Began 2 months after the death of his wife. Ms. Monini, I didn't make these names up, I don't know where they came from, frequently calls or comes to the clinic in a panic, believing she's ill. Her suffering is genuine, but she never has concrete signs of any illness. So, which one is A? So what would A be? I'm just going to go through all of them and see if you can figure out which ones they all are, just based on what we just talked about. So A would be an example of malingering. B, how about B? That would be the Munchausen's by proxy, so a factitious disorder. Okay, difficulty walking using a wheelchair, but he doesn't have any reason for having a wheelchair. That would be conversion. Just think about converting your anxiety into a physical symptom. So conversion, and then frequently coming to the clinic, believing they're ill. So just think about that. Douglas Schlitz video that we just saw. This is what we used to call hypochondriasis illness anxiety disorder. Okay? Alrighty. Oh, okay. Well, we just kind of went through the whole thing there. Okay, so